Hello, I'm Dr. Jim Epstein. Welcome to Chairman's Corner from the 15th Annual European Perspectives in Lung Cancer. The actual meeting was held this past March in Amsterdam, and we're getting together today at ASCO with the two chairs, Dr. Giorgio Scagliotti from the University of Torino and Dr. Peter Postmas from VU University Medical Center in Amsterdam, to talk about the implications of some of the data presented at this year's ASCO meeting and how that reflects back on the European perspectives in lung cancer and how some of this data might affect the practice of oncology in the European community. So, Giorgio, Peter, thank you both for being here. We appreciate this. I know how busy your schedules are at ASCO. It's always a crazy time, and we appreciate your taking the time with us. So we're going to talk about some of the abstracts from this year's meeting and the clinical significance and impact of them on practice, both in the U.S. and in the European community. So, Peter, let's start with you and talk a little bit about unresectable stage 3 lung cancer. You know, over the years there have been a lot of studies looking at sequential chemotherapy followed by radiation versus concurrent chemoradiation, and concurrent chemoradiation has kind of become the standard. But then there have been attempts to try to make things better and improve that progression-free survival by either adding other agents or by doing follow-up consolidation chemotherapy. And there's an international trial, Abstract 7500, presented at this year's meeting, looking at the addition of docetaxel and cisplatin following concurrent chemoradiation with the same two agents. So tell us a little bit about that, what you think that trial has to say, and what its impact might be for the future management of unresectable stage 3.
Okay, looking at this abstract and having seen the presentation, what is striking and what a lot of people always assume that would happen is if you have given combination chemoradiotherapy to this group of patients, then it's very difficult to add any more chemotherapy. That is also demonstrated here. Only 2/3 of the patients got the chemotherapy. Whether that affects the overall outcome of the study, that is unclear. That's not specified by the investigators. Overall, the study is negative, which means that the standard of care has not to be changed. So adding additional cycles of chemotherapy apparently is of no value in this situation.
So the SWOG had done some studies looking at cisplatin etoposide and radiation, and then tried to add consolidation single agent docetaxel. And as I recall, it was very difficult to get through those 3 rounds of docetaxel. And then there were follow-up studies by Hogg and I think in Japan that seemed to feel that that wasn't of that much value. And I wonder why this study was even done when those other studies had already made consolidation chemotherapy.
I don't know what the thinking behind it of the authors was, but apparently they were not convinced that the outcome overall was sufficient enough to say this is what the state of the art should be. So they tried to improve the state of the art, but apparently this category of patients, which is rather old in general, is probably too old, too frail to tolerate so much of a toxic treatment. And I think this study confirms what you just mentioned in other studies. I think this is a dead end for any other study in this area.
So the French have done a phase 2 study, and that's Abstract 7511, trying to add cetuximab to a cisplatin-based doublet, cispam in non-squamous carcinoma. And we've seen cetuximab previously in a number of non-small cell lung cancer programs, including the FLEX study from several years ago at ASCO. And I've always gotten the impression, speaking to experts in the field, that cetuximab really did not have that much value. But what about this French phase 2 study? Did it appear to show any benefit?
Looking at that abstract and the presentation, the first thing that strikes me is that they did not break down or stratify for the H-score, which has been proven to be of value for cetuximab. So I think that is at least something I would like to know what is the value of that, and if the authors have done that. Overall, they conclude that it's tolerable, but the toxicity grade 3 and 4 is considerably high. So I really have my doubts whether cetuximab in this situation will be of any benefit for these patients.
Very good. Giorgio, any thoughts about these trials in unresectable stage 3?
Well, I believe that the issue of consolidation chemotherapy after concurrent chemoradiotherapy has been always an open question, because even if you are using historical data, there is no clear evidence that you need to add something in addition to the concurrent chemo and radiotherapy approach. So when you're looking to any study in the past, there is no clear evidence that 4 courses of chemotherapy versus 2 courses of chemotherapy using concurrent chemo and radiotherapy is ending up in a better benefit for our patients. And obviously the first study that you was discussing with Dr. Posmus, it's another study that is saying, well, we need to deliver concurrent chemo and radiotherapy. Is the synergistic effects between the 2 treatment modalities that is generating the survival advantage. When you are trying to add something on, even only in terms of consolidation chemotherapy, you are not generating additional improvement in survival, but potentially you are increasing the toxicity in the worst case scenario. That is the case of the phase 3 SWOG study that was trying to establish on the platform of concurrent chemo and radiotherapy followed by maintenance docetaxel, the randomization between placebo and gefitinib. And gefitinib ended up to be inferior to placebo, but I do not believe that we should blame gefitinib versus placebo, because probably is the platform approach that was wrong, because there were other studies. One was the OG study that didn't show any benefit in the phase 3 contest of doing maintenance with docetaxel. Consequently, the idea of maintaining the response or the disease stabilization with combination chemotherapy is not completely proven. For the second abstract, I believe that we are getting close to the idea that there is no room, differently from head and neck cancer. There is no room for cetuximab in combination with chemo and radiotherapy in the management of locally advanced non-small cell lung cancer. You can dissect the data as you want, but the general concept for practicing physician is that apparently this specific targeted therapy administered in all comers is not of any benefit for our patients.
Very good. Well, Giorgio, while I have you, let me ask you about the RADIANT trial. This is a trial that has been looked forward to for a number of years, the adjuvant use of erlotinib in completely resected EGFR mutant patients. So EGFR mutant and EGFR overexpressed. So how did that trial work out? Does post-resection use of adjuvant erlotinib prolong progression-free survival, or is this still an unanswered question?
Well, you need to make your personal judgment on a couple of considerations. The first consideration is that any adjuvant study needs a long follow-up time. So the study was planned in a period of time where the EGFR mutation were just starting to be explored outside of a academic context. The study was looking to a couple of co-primary endpoints, looking to EGFR FISH. Again, we need to go back to almost 10 years ago when there was this ongoing discussion between EGFR mutation and EGFR FISH. And one of the co-primary endpoints of the study was the FISH positivity, as well as another molecular assessment was looking to EGFR immunohistochemistry. That was in some way a broad way to enrich the patient population. As I said before, it takes a long time to get data on progression-free survival and in general to get outcomes events. Now, the study conclusions are overall negative because obviously there was no improvement in progression-free survival and no improvement in the overall survival. But the interesting finding are that at least in those subgroup of patients who were EGFR mutants, the improvement in PFS was there. They were not able to show any improvement in overall survival. But that is something that is again leading back us to the studies that were comparing in metastatic disease a targeted therapy versus cytotoxic chemotherapy, in which we didn't see any benefit or any change in overall survival. So I'm not quite negative about the outcome of this study. Obviously, this study needs to be redone using probably different molecular selection criteria that they were just at the beginning at that time. And I'm not so quite negative also considering the outcome of this study. I'm trying to compare the results of the Radiant study with the Canadian study that has been presented a couple of years ago. You remember, the patients were treated with adjuvant chemotherapy, then they were randomized to receive gefitinib versus placebo. The study was stopped earlier based on a interim analysis and based mainly on the negative outcome of the SWOG study in locally advanced disease and the negative outcome of the second-line gefitinib versus docetaxel study, the INTEREST study. Well, you have to take into consideration that in the BR19, not every patient of these 600 patients randomized received a sufficient period of treatment to be considered effective. And consequently, even if there was no benefit in the EGFR mutants, this is something that is not jeopardizing the positivity or the positive findings that we saw in the Radiant study.
Right. Well, let's stay on the topic of EGFR mutant, and let me ask Peter about the first-line study that has been presented here at ASCO, combining erlotinib with bevacizumab. I mean, erlotinib has been the standard, and now there are other drugs looking at maybe taking over that, but at least in the United States, where gefitinib is not available, erlotinib has been the frontline standard based on a number of studies, including IPASS and YORTAC and others. Does the addition of bevacizumab to frontline erlotinib really make a difference, or does it just add toxicity?
Looking at this abstract, there are two things very striking. First, it's a very positive outcome in a randomized phase 2 study, so small number of patients. And the other thing is the toxicity is considerable. I think the first message is for me the most important. It shows that you may improve the outcome of erlotinib alone. The toxicity is an item, and part of the toxicity is certainly due to the dose of erlotinib. It's by far uncertain if the dose of erlotinib of 150 should be the standard dose for. It has been tested always in that way, and then the registration has been in that dose, but we've done patients at a much lower dose with the same, more or less the same response rate. So I think it might be possible to extend on these outcomes to try to improve the toxicity and still maintaining the efficacy of the combination of both. And I think it's worthwhile for the company, if they're interested, or for groups, cooperative groups, to work on that in that area.
Right. So maybe perhaps a dose modification would preserve efficacy and improve safety. Well, that's very good. We'll see whether or not that idea moves forward. One of the problems with the EGFR mutants, although so many patients respond to gefitinib or alatinib, eventually they progress. And we know that there are a variety of different mechanisms, different mutations, especially the T790 mutation, which is probably about 50% or so of the progressions. But there's also MET amplification and HER2 overexpression and a variety of other mechanisms. There have been a number of attempts to improve the situation for those patients who progress on first-generation EGFR TKIs. Afatinib has recently been approved. There's even been a study combining afatinib with cetuximab, which has been pretty impressive but also pretty toxic. And now there are some third-generation drugs, and we heard about several of those in today's Clinical Science Symposium. So tell us about these new third-generation EGFR TKIs and how they differ, and what sort of results are being seen in patients generally previously exposed to the first-generation agents.
Yeah, I've seen those two or three presentations. One was on the Clovis drug, the other was on AstraZeneca, and there was a Korean presentation. What's happening, in fact, is if you treat a EGFR mutant case, you're selecting out within a tumor a subset of tumor cells that is not sensitive for the drug you are giving. So the sensitive clone is disappearing or inhibited very strongly. The other clone that's not inhibited at all is growing. T790M is growing slower normally than the T790M negative clone, EGFR mutant. So what you see in these cases now, that there is kind of overgrowth of T790M mutant cases. The number of cells in the tumor biopsy is much larger than it was initially, simply because that clone has been growing.
Right. You've killed off the others.
Yes, killed off, at least you reduced it considerably.
Them, yeah.
I don't think you killed it off all, because if you do a rebiopsy later on, you will find again
some of them are still
sensitive for alatinib, sensitive for gefitinib, and also clinical benefit if you add in that situation again the drugs you initially used but stopped them for a period because you give chemotherapy or something else. So it is the treatment you do is kind of driving out a clone or inhibiting a clone, and then another clone gets the chance to escape that, and that is going to be treated. What has now been shown with these 2-3 new drugs, that this specific clone is inhibited very well and produces very nice progression-free survival, especially the Clovis drug had a progression-free survival of over 12 months. These studies are still pretty early, so they have to mature. And I think those are really promising, but what I expect is after some time, after these drugs have been worked out, there will be again resistance, and there's going to be a different clone, which will again needs to be treated. Maybe it's the same clone as we had in the beginning, which is now regrowing again, and maybe it's sensitive for drugs we already have in our portfolio to use. So it's moving and moving and moving.
Yeah.
So this is an example of what you see, and specific in this disease category, that lung cancer is becoming a chronic disease with chronic treatment. It's not you do something and it's over. No, you do something, it's going worse, you have a new treatment again and again, and still patients live longer.
So in hopefully turning these patients or their illness into a chronic disease, one of the most important things is going to be maintenance of quality of life. And,
that's very nice for these
right.
drugs, because
I was struck by the difference.
Yes, the toxicity is lower. Apparently the wild type EGFR was not hit by the dose they gave, and already had efficacy against the tumor cells, which is very much appreciated, because these are rather non-toxic drugs.
Yes. So the AZD 9291 and Clovis Oncology, CO1686, and then the Korean agent, these are all still pretty early, but pretty exciting. So Giorgio, what What do you think is the future for these agents? Are these going to be a major breakthrough in EGFR mutant non-small cell lung cancer?
Well, if you're referring to the FDA recent approval for the two drugs, we are facing through two, at least the Clovis and the AZ agents, that they are considered breakthrough drugs. From a patient's perspective and from a physician perspective, I see the story in a more practical way, because we know that at the time of the relapse of the disease, at least 60% of 50 to 60% of these patients with EGFR mutant tumors, they have a T790 mutation. And it's quite likely that the proportion of patients with T790 mutation will increase over time with more sensitivity in the molecular diagnostics. Based on the data presented this morning, at least for the Clovis drug and for the AZ drug, we have a progression-free survival in the T790 mutation detected at the time of the relapse of the disease that is ranging between 7 and 12 months. Let me give an average estimation of the progression-free survival time, just to use these numbers to put in a sort of historical perspective for the patient. The patient quite likely already received the first generation reversible TKI. He got a progression-free survival around 9 to 10 months. At the time of relapse, you are detecting the T790 mutation. You are extending the progression-free survival of another 7 to 12 months. You are ending up already in a progression-free survival 1 plus progression-free survival 2 that is exceeding 20 months. That is definitively a new step forward for these patients. As you said before, we are slowly moving in the field of considering lung cancer, at least for this subgroup of patients, a sort of chronic disease.
Right.
But we know we know very well that these kind of tumors are changing very quickly, and sometimes they are turning back to be dependent from the original pathway. So it could be that in the near future we will do a third biopsy, and we will find that the original pathway that was mutated, it is again mutated. There are just simply isolated case reports, but this is something that we need to take into account. And that is the reason why I consider these two indications really breakthrough indication for these kind of patients.
Very good. And we know that some of these patients, besides T790, some of them will express markers that suggest a small cell-like pattern and then respond to cisplatin and etoposide. Some of them show MET amplification and overexpression. Some of them have a epithelial mesenchymal transformation change. But with MET, over the past few years, there's been a lot of studies looking at MET inhibitors, some of them small molecule inhibitors, some of them monoclonal antibodies either to the ligand or to the receptor. But one of the studies that has been awaited for a number of years is the MET lung study with onartuzumab, the monoclonal antibody to the MET receptor. That data turned out to be somewhat disappointing.
Well, not for me, because because I was looking carefully to the phase 2 data, and the phase 2 data have been generated in a too much tiny patient population.
It was small.
And obviously, when you are making your strategy based on a limited number of patients, and you are just looking to the average treatment effect, you are not considering the 95 confidence intervals. This is leading you in a risky field, even if you are trying to select the best patient population that, according to the existing knowledge, is that population that is potentially able to guarantee you some kind of success. It's a matter of fact, the immunohistochemistry is a semi-quantitative technique.
Right.
The assessment of +2, +3, even if you are centralizing the assessment, it's always a semi-quantitative technique. And in addition to this point that led in some way to a study that we can consider globally negative, because there was any improvement in the efficacy endpoints, at least from what the authors have been reported at this meeting. It's obviously there will be additional subset analysis to dig further into the data, but the key message for me, again, when you are looking to molecular diagnostic, you need to look in a more comprehensive way, not in the most easy way to look to the most easiest marker or the easiest method to detect.
So they used the MET diagnostic, high versus low, whereas there was another trial presented this year with crizotinib, which we already know is approved for ALK-positive lung cancer, but it's also a MET inhibitor, a tyrosine kinase inhibitor. And in that trial, they defined their patient population on the basis of MET amplification by FISH. Is this a better way to determine the target population?
Let's say that based on our internal experience, looking to multiple cell lines, the only cell lines that they were truly sensitive to the MET inhibition using monoclonal antibodies were these 3-4% of the cell lines that were really MET amplified. And if you are looking carefully also to the abstract that Dr. Kemich presented at this meeting, when you are looking to the very high amplified cases, the response rate, obviously with the limitation of the low and extremely limited number of patients, the response rate is in the range of 50%. Why, when you are using lower cutoffs for amplification, the response rate was lower? So consequently, I believe that for at least for the c-MET amplification story, the next step could be to do a sort of basket study that is looking to the c-MET amplified tumors independently from the site of origin. So I'm saying that I can look to colorectal, I can look to lung, I can look to any kind of solid tumors in which you can detect a c-MET amplification, and then you can do a single arm study, or you can do a phase 2 randomized clinical study if you believe that there is no enough evidence to proceed with a single arm study.
Very good. Well, I don't want to keep you guys too long this morning, but I do want to talk a little bit about some of the data that is yet to be presented. And one very important study, I think, is with the novel VEGFR2 monoclonal antibody ramucirumab that is already looking very strong in gastric cancer. And now the Ravel trial is going to be presented at this year's meeting. But there's already been a press release a few months ago from Lilly Oncology giving some results in improvements in progression-free survival and improvements in overall survival for a drug, biologic agent combined with a second-line chemotherapeutic agent, docetaxel, in second-line therapy. Is this really a significant improvement? Do you think this is going to be something that is going to significantly impact that group of patients who don't have an easily identifiable oncologic driver?
Well, angiogenesis is a story and is a pathway that is quite different from the EGFR pathway or from the ALK pathway. And consequently, in angiogenesis, the story is much more complicated. There are multiple factors. We are not able to identify a surrogate biomarker that will pick up where the agents or the anti-angiogenetic agents are more active. It's a matter of fact that looking specifically to the study that you was just mentioning, it's a study that is positive for the primary endpoint we can discuss how much positive these data are. It's positive for the progression-free survival data, and it's positive in some way also for the objective response rate. Okay, the problem, at least for me, and this is really my personal interpretation, is the chemotherapy backbone. The chemotherapy backbone itself is already toxic because it's a common daily clinical practice. In second line, you can administer 2 or 3 cycles of Taxotere, and then the toxicity, mainly in terms of hematological toxicities, but also non-hematological toxicities are coming up. You are starting to delay treatment, and then you stop treatment. So when you're looking carefully to the toxicity profile of the combination, the combination is suffering a little bit by the toxicities of the backbone agent, and consequently, that is something that we need to consider even for future combinations. In my view, this study, as well as with different kind of data, the BI study looking to BF 1120 in combination again with docetaxel, was showing some survival advantage, mainly in patients with adenocarcinoma, with some restrictions for those patients who were progressing less than 9 months from the start of chemotherapy. But overall, there is a new interest in angiogenesis in the field of second-line non-small cell lung cancer, where the therapeutic options are still stacking to what we got almost 7 or 8 years ago. When you're looking to the guidelines, the standard of care is docetaxel, pemetrexed, and erlotinib, but erlotinib now is not administered to the all-comers because there is a striking evidence that the activity is virtually confined to the patients with EGFR mutation. There is still a label indication, but practical physicians are reducing the proportion of patients that are currently treated in second line with erlotinib. Well, it's a new treatment possibility. I don't know what will happen in the near future with this data at the regulatory level, but at least at scientific level, it's something that we need to consider carefully.
Right? Well, Peter, let me ask you, another agent that has been presented at this year's meeting is a novel anti-EGFR monoclonal antibody. We've already talked about cetuximab and the fact that there have been problems with it, both in unresectable stage 3 and in the advanced disease state. But now this new agent, necitumumab, has been looked at in squamous cell carcinoma, in addition to the combination of cisplatin and gemcitabine. So this is a phase 3 randomized trial, cisgem with or without necitumumab in squamous cell. And does this look like there is activity here? Is this something that we should look for more data on, or is this going to be ready for prime time?
The study is positive. There is no doubt about that. It's positive for overall survival and progression-free survival. It's unclear whether there are subgroups within the study that benefit more than others. Maybe some who have a better H-score, so the presence of the EGFR receptor, might benefit more. If that is the case, then that might be a stronger argument to add that to the, let's say, the workup of the patients, and it might be a way to select patients to be treated with this. If that is not the case, then this study is in general, I think, one of the first ones in squamous cell lung cancer that is demonstrating improvement by adding a drug, in this case a monoclonal antibody, to the standard chemotherapy. And that is what we have not seen for a very long time in squamous cell lung cancer. So knowing that this is positive, that is to some degree a small breakthrough.
How common is EGFR overexpression in squamous cell? Is it pretty frequent?
Yes, very frequent.
So this may well have a role there. And squamous cell has, as you said, been a tough nut to crack. So
the outcome of this study more or less confirms what you saw in a subgroup analysis of the FLEX study. Those who had more expression in the squamous group benefited more. I expect that will be the same here. I'm not sure whether it is because the data are not there.
Oh, good. Well, I want to thank both of you for stopping by and giving us your perspectives on some of the data from this year's meeting. And I know that the European Perspectives in Lung Cancer is a very well attended and very well received meeting, and you're both to be congratulated for all the work you've done on that. And thank you so much for coming by today. And thanks to all of you for watching this segment of Chairman's Corner with the chairs from the European Perspectives in Lung Cancer meeting. Thanks so much.